Thank you, Travis, for that wonderful introduction, and thank you to the organisers of this conference for inviting me to share some of my thoughts on paediatric PSC. So what I thought I'd try and focus on is what is the difference between paediatric and adult PSC, because you've heard a lot about PSC from many and varied speakers yesterday and today. So what I wanted to do was talk not only about the differences, but also about some of the new research in paediatric PSC and some of the treatments that are available for paediatric PSC. And the reason I've got pictures of random trees in the bottom of my slide is that this is the sort of analogy that I use when I'm seeing the family of a child who's newly been diagnosed with PSC. And I like to describe the liver like a tree. With the liver cells themselves being the leaves. They're doing all of the work, metabolic work, and they're making bile. And they are excreting it into these tiniest little branches, which I like to call as bile ducts. They then join to form bigger and bigger branches until we get the main trunk of the tree, which is the main bile duct or common bile duct. Now, in PSC, we know that there is damage to the biliary tree, scarring and damage to this biliary tree, so that the bile that is being produced by the liver cells cannot get out of the liver. And as a result, there is damage to the liver cells and death to some of the liver cells. And so you can see in this picture on the right, you can imagine that the bile duct that's supplying this part of the tree has been damaged. And so these liver cells are not looking very healthy, whereas other parts of the tree are. So let's get on to what's the difference. The first thing, and I know I was told not to talk about statistics, but doctors can't resist statistics. So the first thing to tell you is that paediatric PSC is much rarer than it is in adults, almost 3 to 4 times rarer. So in the USA, for every 100,000 children, there might be 1 or 2 cases of PSC, whereas in adults, for every 100,000 adults, there'll be 4 cases of PSC, almost double. The other thing you'll notice both hearing in talks and when you're looking at the literature is that we use GGT, gamma-glutamyl transpeptidase, as a marker of bile duct injury in PSC, whereas when you've been hearing other talks or reading about PSC in adults, you'll notice that they use alkaline phosphatase or ALP. And the main reason that we use GGT is that ALP is something that is excreted from bone and children are growing. So ALP doesn't give a good idea of bile ducts. It gives much of a better idea of bone growth. And so that's why we refer to GGT in pediatrics. The other difference is that children, when they present, tend to have much more abnormal liver function tests than adults do. So they'll have a higher GGT, ALT and AST. In addition, there is a higher prevalence of a condition called autoimmune sclerosing cholangitis, which I'll talk about a little bit later. And the main difference between this and primary sclerosing cholangitis, or PSC, is that autoimmune sclerosing cholangitis responds to steroids like autoimmune hepatitis does. And we all know that PSC does not respond to steroids. You may have heard already in the talks to date that there's a slight difference between PSC that affects the small bile ducts, or small duct PSC, compared to large duct PSC. And we know that small duct PSC has a better outcome, and this is more common in children. Finally, you will have heard of cholangiocarcinoma as a complication of PSC, and this is very rare in children. And in any discussion of children versus adults, we have to take into account school, growth, and puberty. So what about the clinical picture? If you or a family member have PSC, you know that most children will present around the age of 12 years, with mainly males being involved. The symptoms are very non-specific: tiredness, tummy pain, a poor appetite. Or if you are one of the majority that also already has inflammatory bowel disease, ulcerative colitis or Crohn's disease, it may be that your doctor has been screening liver function tests and has discovered the PSC on these screening liver function tests. Indeed, we know that about 3/4 of children with PSC either already have or will get inflammatory bowel disease, and most of these children will have ulcerative colitis as opposed to Crohn's disease. In contrast, if you just have IBD to start with, only a small percentage, less than 1/4, will develop PSC. About 1/3 of children with PSC will have this overlap of autoimmune sclerosing cholangitis, which I mentioned in the previous slide, which is steroid responsive. And in children, if a doctor is diagnosing sclerosing cholangitis, we want to be sure that it is primary sclerosing cholangitis, which is what we're talking about today, PSC. And primary basically means we don't know what the cause is, whereas secondary sclerosing cholangitis produces changes in blood tests and X-rays that look like sclerosing cholangitis, but are not sclerosing cholangitis. And in this slide, you'll see some of the other causes of these sclerosing cholangitis-like illnesses. And these are things that your doctor will be looking for to make sure that they're not the cause. So what if you are one of the 3/4 of children who already have or are about to get inflammatory bowel disease? We know that children who have ulcerative colitis as well with their PSC tend to have what we call pancolitis. In other words, the entire colon is inflamed. They also tend to get something called backwash ileitis, which is a little bit of inflammation in the last part of the small bowel, thought to be due to reflux of contents from the colon back into the small bowel. We also know that the ulcerative colitis tends to be milder in people with PSC, and that they're able to be treated with relatively mild medications by their ASA group, such as mesalazine, pentasa, Mesavant, etc. And you're more likely to have your bowel disease under control. The risk of using a much stronger medicine like a biological or having to take the colon out is again lower in people who have PSC as well. The only caveat is that if you just use symptoms to work out how bad the bowel disease is, you would be undercalling the bowel disease in somebody with PSC. So people with PSC tend to not complain very much about their bowel symptoms. And in fact, when you do a colonoscopy, you actually see the true extent of the inflammation. So it may be that your doctor is tending to do calprotectins and do colonoscopies to look at your bowel a little bit more often, even if your symptoms are not that bad. Okay, so you've been given the diagnosis of PSC. What's next? We always want to know what's going to come, what's around the corner. So we have the results of this very large study, which is a retrospective registry study, which means they've collected data on children who already have PSC, who are already being looked after by their individual doctors to find out what happened to them. And we know that the median age of presentation is around 12 years. So we know that even after 10 years, half of the children were pretty stable. Nothing much had happened to them. The other half had developed some complications related to portal hypertension, which is scarring of the liver, fibrosis and scarring of the liver, or some biliary complications such as infection of the bile ducts or narrowing of the bile ducts. We know that if you've got inflammatory bowel disease, you tend to do a little bit better. We know if you've got small duct PSC, you need to do a little bit better. But if you've got really bad liver function tests when you first present, then you might not do quite so well. We also know that there is no effect of age, gender, or whether you've got autoimmune hepatitis on affecting your outcome. Now, these are all general statistics, but what about the individual in front of you or your child? How good are we at picking what's going to happen next in a particular person? So a group, the sclerosing cholangitis cohort have looked at this thing called the SCOPE index, which is sclerosing cholangitis outcomes in pediatrics. And what they did was use a group of commonly measured markers such as bilirubin, albumin, platelet count, GGT, and cholangiography, and put them into a formula to try and predict what the outcome in an individual patient might be in terms of their need for transplantation or their risk of other complications such as the ones we were talking about before, of portal hypertension, etc. And using this scoring system, they were reasonably accurately able to predict the likelihood of some of these complications in timeframes on an annual basis, risk per year. And this scope index can be used for shared decision-making with you, between you and your doctor, in deciding clinical care needs based on a patient's individual risk and their risk of progression. So just to give you an idea of the scope index, here's the sort of things that we're measuring and dividing them into categories, giving people points, and then depending on how many points you get, you'll be able to work out what the risk of progression is, just to help you do a little bit of planning. Okay, what about treatment in children? You will have heard about treatment in children from some of the other doctors and people who've been speaking today and who will speak. So the main problem with treatment is PSC is that we don't know the cause. We have theories on what the cause might be, and therefore the different treatments are related to the different theories on what the cause might be. There are some who believe that it is related to toxic bile. The bile itself is toxic, and if you're able to change the bile acid pool, that might help the disease. And so things like ursodeoxycholic acid, obeticholic acid, and some of the newer inhibitors of bile acid transport are directed at that theory. There are others who believe that the microbiome, the bugs in the gut, are abnormal and that they are causing the problem, and that's where treatments like vancomycin, probiotics, and fecal transplant come in. There is still another theory related to immunology, that there are abnormal white blood cells that track between the liver and the bowel because of the association of inflammatory bowel disease, and that maybe they are causing the problem. No specific treatments directed at this at the moment. And then there are others where we know that there is an issue with inflammation and fibrosis in the liver, and that perhaps if we can slow down the fibrosis, that will impact the disease. And that's where things like obeticholic acid and some of these other treatments come in. So what about children? What's the evidence for using ursodeoxycholic acid in children? Well, this is another consortium study with 309 children, and they looked at what are your chances of having no problems over 5 years if you have what's called a biochemical response. In other words, if you're on ursodeoxycholic acid and your gamma GT is normal at 1 year, what they found is that 90% of children had 5 years of good health. The only problem is they also noted that if you don't have ursodeoxycholic acid and your gamma GT normalizes at 1 year, you also have an excellent 5 years of good health. So it seemed to be that normalization of the GGT was more important than whether you used urso or not. In another study, people who were well established on urso and doing well had a withdrawal of urso, and they found a third of them got significantly worse and another third got a bit worse, whereas a third, nothing happened at all. All of these flares of liver function test abnormalities were able to be recontrolled by urso. So we've got two lots of studies here which seem to show conflicting results. What about vancomycin? So vancomycin as an antibiotic may be treating the abnormal bugs in the bowel, but it may also work in a different way, in that it may help to modify the immune system. It is known that vancomycin increases the number of Tregs, which are T regulatory cells, which help to dampen down the immune system, which we know is active in both PSC and inflammatory bowel disease. And here we have two small studies in children, one with only 14 and one with 59 patients. Both of them are open label studies and used vancomycin. And we found that there were improvement in symptoms of inflammatory bowel disease, improvement in liver function tests and liver biopsy findings, and improvement in immune changes. However, you'll see that these two studies are pretty small. This is another study that compares using vancomycin, ursodeoxycholic acid, versus nothing. And there were 88 children in each of these three groups. But again, it is retrospective data from this Paediatric PSC consortium. And basically, they found no difference in whether your liver function tests normalized, whether you got more scarring or the same amount of scarring, or your chance of needing a liver transplant listing within 5 years. It made no difference whether you'd been on vancomycin, urso, or whether nothing at all happened. So have I got you thoroughly confused by these treatment trials? I can understand if you are. How do we reconcile these different studies, particularly when you as parents are reading the literature and using Dr. Google to try and work out what the best thing is for your child? What I'd like you to do when you are reading Dr. Google and reading the studies is to look carefully at the studies, all right? Some of these studies are retrospective. That means they're looking back at what already happened, versus a prospective studies where you take a group of people with a particular disease and use a treatment and follow them forward. Prospective studies are much more scientifically robust than retrospective studies, and I'll explain why that is in a minute. The next thing is comparing small versus large studies. I show you the vancomycin studies, which were really successful, but they're very small studies. So we really need much larger studies to work out whether vancomycin is really going to be as good as it claims. Similarly, when you're introducing a new treatment, it's very good to compare it to something. You either compare it to standard of care or nothing, or placebo. And these placebo-controlled trials are much more useful than an observation or open label study where you just give a group of people a drug and see what happens. And then finally, it's very important to make sure the people that you are studying are a uniform group. So I've already told you that people with inflammatory bowel disease might be different from those without inflammatory bowel disease. People with small duct PSC are different from people with large duct PSC. So when you're studying a particular treatment, it's really important that all the people you are studying are similar to each other. So the best example I can give you is with the ursodeoxycholic acid trial or the vancomycin trial. We don't know why those doctors chose urso. So, for instance, say that we had a group of children and some of them had very mild disease and some of them had very bad disease, and they're all mixed up in one group and everybody got urso. It may be that the urso worked very well in the mild disease and didn't work at all in the bad disease. And when we add all those results together, you get no effect. And you can't tell the fact that it was better in the children with mild disease and not at all effective in the children with bad disease. And that is why these prospective, randomized, placebo-controlled trials are really what we need to try and work out what the best treatment is for children with sclerosing cholangitis. What about liver transplantation? What if your child does have very bad liver disease and needs a liver transplant? Well, we know that needing a transplant in childhood age group is pretty uncommon. So of the transplantations that are done, for instance, in the US, only 2% are done because of sclerosing cholangitis. The biggest study of children who have sclerosing cholangitis and have had a transplant comes from what's called the split registry. And in this study of 80 children, they found that about half of them had inflammatory bowel disease, and about 10% of them actually got inflammatory bowel disease after the transplant, because we know these two diseases are linked. The good news is that patient and graft survival was exactly the same as for transplant for other causes. And this is good news because it means that having PSC doesn't mean you have a worse transplant outcome. The other important thing is that unfortunately some diseases that we transplant for can actually recur after transplantation, and PSC is one of these diseases, but it does only recur in about 10% of people who are transplanted, which means 90% it doesn't recur in. So When looking after your child, family member, relative with PSC, the important things to consider in children, particularly, as I said before, are growth and nutrition. We know that children who have PSC and IBD have generally milder IBD, inflammatory bowel disease, but they have greater growth impairment. So it's very important to pay attention to healthy and appropriate diet. School attendance is exceptionally important for mental and social well-being, and good attention to mental health and family support for both the child and for the family looking after a family member with PSC. So, to conclude, paediatric PSC is generally a milder disease. Unless you are very sick at diagnosis and have established significant scarring of the liver when you are diagnosed, you can expect to have a good 5 to 10 years without any major complications. There are new and evolving treatments which will come into play for PSC, which are not on the main stage yet. And if your liver disease does progress, then liver transplantation is a very well-established treatment option. So with that, I'd like to thank you for your attention, and I will be online later to answer questions. Thank you.